Good morning, everyone. It is Thursday, January 29th, and today in the State House is Mental Health Advocacy Day. So we thought that we would bring in some representatives who with various organizations so that they can tell us about themselves and what they do for Vermonters. And first up, we have Kathleen Kilborn.
Thank you.
Kathleen, for being with us.
Good morning. I appreciate your time and interest, the opportunity to share about NAMI Vermont, the National Alliance on Mental Illness of Vermont, with you this morning. I'm actually going to share testimony that was co-created with Lori Emerson, our executive director, who's not able to be here in this exact seat today because she's just one building over for Mental Health Advocacy Day. But much of these were actually her words that I'm sharing today. But I will first start by introducing myself. My name is Kathleen Kilborn. The things you should know about me is, for context, is that I'm an educator and a principal and was for 28 years in public schools in Vermont. So I bring that context to this conversation. I've been a foster parent, an adoptive mom, and a bio mom. So youth is quite important to me. And lastly, and perhaps most relevant to this conversation, is I'm a suicide loss survivor. So in 2020, someone I love dearly took his own life. I'm working part-time at the National Alliance on Mental Illness of Vermont, and I'm here representing that agency today. The testimony that I bring to you today is both personal and professional, as you might have expected from that introduction. But this mental health work is now really my why. It's shifted. It was education, and it continues to be education, but now education around mental health, or as we like to call it, brain health. We have heart health, we have lung health, and we have brain health. And maybe if we called it brain health and not just mental health, that would help reduce some of that stigma and how we approach support and services. So, Madam Chair and House Healthcare Committee members, today is our 11th year in bringing together over 40 co-sponsors or 40 co-sponsoring organizations and their networks for Mental Health Advocacy Day at the State House and the Vermont Supreme Courthouse Auditorium. We appreciate you inviting us to testify for your committee today. We'd like to do a special thank you, of course, to Representative Berbeco and Representative Sina for the resolution recognizing Mental Health Advocacy Day, and for Representative Berbeco as one of our keynote speakers at our morning program. In the spirit of transparency, Daisy also sits on our board of directors for NAMI Vermont. So if you have more questions, she'd be happy to answer them, I'm sure. So who are we? Who's NAMI? NAMI Vermont is an independent state charter of the National Alliance on Mental Illness, which is a statewide nonprofit. It's a grassroots organization run heavily by volunteers, and it was incorporated in 1984. There are over 600 chapters of NAMI and affiliates throughout the country, so it's not specific to New England or just Vermont. Our mission at NAMI Vermont is to support, educate, and advocate so that all communities, families, and individuals affected by mental health can really build better lives, even though they face some challenges. Our core competency is really valuing having lived experience as family members, caregivers, peers, and individuals with mental health conditions. It's really a critical asset in creating safe spaces for conversations and questions and finding resources about mental health. Who do we serve? The community, family members, peers, and individuals affected by mental health conditions, and the professionals who work with them. A quick snapshot of statistics. In Vermont, mental illness affects approximately 1 in 5 adults and 1 in 6 youth age 6 to 17. That's 1 in 5 individuals. Nearly 1 in 20 adults are living with a serious mental health condition, such as schizophrenia, major depression, bipolar disorder, for example. Despite these statistics, it's really important and critical to remember that most people with a mental illness can and do lead very fulfilling, productive lives with access to effective treatment and care, community and family supports, and good self-care. So what do? From parenting classes to in-person and remote support groups to presentations, staff and volunteers administer all of our free programs that focus on education, support, and advocacy. Those are our 3 pillars. My testimony today will focus specifically on community connections for youth and families. So NAMI Vermont is launching a new initiative called the Uplifting Youth Voice to Advocacy Program for Mental Health Policy Reform. It's designed to equip high school and college age students with skills and supports to become the next generation of mental health advocates. This effort strengthens youth influence in public policy by engaging young people directly and identifying and speaking up about what mental health issues that matter to them the most. We need more legislators to help with this initiative. Representative Bebeco and Representative Boslan have already confirmed their involvement. From January to June of 2026, youth ages 14 and above can join our youth mental health advocacy cohort. They will receive advocacy training, practice sharing their testimony, and meet with legislators and receive some ongoing coaching and mentorship. We're partnering with youth-serving organizations to ensure safe, inclusive environments where young people can elevate their priorities and really help shape mental health policy in Vermont. To that end, today, I have been partnering with Job Corps in Vergennes, and they are here with a group of students today for the first time in the State House. And so I welcome the opportunity, not just for them to see and understand the process, but to become part of that conversation. We seek additional legislators who can mentor and coach youth advocates and listen to their testimony. If you'd like to be involved, please reach out to me directly or go to namivermont.org/youth. As we mentioned, we are a nonprofit, so all of our services are free to consumers. What that means is we don't need to know what your insurance is, and there are no financial barriers to access those supports or services. And we do that statewide, both remotely and in person. We are 100% funded by grants, sponsorships, donations, partnerships, and volunteers. To that end, we must have an annual fundraiser. And to me, my title actually at NAMI is Events and Fundraising Coordinating, although that's one piece of the role. I also volunteer to do other things like lead parenting classes, and I go into high schools and college campuses and teach a program called Ending the Silence, which is about helping youth to understand it's okay to ask for help, how to access help, what is 988, is it really confidential, answer their questions. In that program, Ending the Silence, I go with a youthful person with me, because while I can deliver content, statistics, support, and resources, it's really important that they connect with someone closer to their own age. And we know that what that youth says in their 15 minutes is going to way outweigh what I say in my 40-minute presentation. And so for street cred, we do that together with someone who is more youthful and who has lived experience to share. So that's Ending the Silence. But we are having a walk, the NAMI walk that we have annually. This year it is May 16th, United Day of Hope. We would invite each and every one of you to come. You do have to register. It's free. You don't have to fundraise to come. Yes, my job is to create enough financial support for these programs to continue. However, as a suicide loss survivor myself, the other half of that day for me is to create a safe space of community where people can come and bravely show up to be themselves and do that without stigma or judgment present. We know the largest, there's many risk factors, but the largest protective factor that we know, both through practical application and research, is human connection and relationship. So that's really what that day is about. It's about allowing people to meet other people. We create at this walk what I'm calling a resource buffet, because who doesn't love a good buffet, right? You go around, pick what you like. So the resource buffet will have over 40 vendors of nonprofits, and our walks and participants can go through and choose the supports that matter to them and their family at our resource buffet. We'll have a silent auction. There's 2 food trucks. There's a live band. It's a festival environment. It's a day of connection and fun. And hopefully while doing that, we raise funding for these programs to continue. But people can come and not fundraise at all and just enjoy the day. So I will leave you with information about that on this little card for Save the Date, so that if you're not able to come, perhaps you are able to share this information. Because when people say, who does NAMI serve? I like to say human beings. We all have brain health. To that end, we also have a new grant through UVM, and we're doing some community conversations where we're going to have 3 to 4 panelists, professionals in the field, and those with lived experience, peers as well, who will create a safe space to have conversations and ask questions. These topics will range from Vermont authors who write about mental health, because that's a bit of a softer entry and landing, but then perhaps some of the tougher topics to talk about. So if someone isn't yet ready to say, I'm looking for support and help, they might very well be willing to come to an author talk, right? So it's a soft entry point with intention. We also will have a conversation about the challenges in Vermont for LGBTQ folks and people in that community to access services. And certainly they are under many more stressors than some of the other populations. We're having one group about postnatal care and postpartum, right? Something that doesn't get talked about a lot. So there's a variety of those community conversations that are up and coming. You can check our website. We also, lastly, I will just talk about basics class quickly. We teach a parenting class online. I'm one of 2 facilitators for that course. It's statewide because it's online, free of charge, and it allows parents to meet other parents who are also supporting their own children and their communities. And we give them some very basic structural information and hook them up to resources and help them know what questions to ask and how do you navigate an IEP meeting and how do you, ask for help or get that fuel in your tank? We talk about basic needs and then we talk about what they want to talk about. Like we have an agenda, but we also have space for them to just bring what's important to them in that moment and be a listening ear with some empathy and grace. So it's really important. That begins in March. I am happy to answer questions, have conversation. I do want to respect the time. I know there's other speakers today, but I certainly am highly engaged in this topic and would be happy to talk individually or collectively after this if you have more questions or an idea for a project or want to talk to me about how to engage with NAMI Vermont. I'd like to just thank you for taking your time and interest to listen to my testimony today. What we do at NAMI Vermont statewide is life-changing and it can really be life-saving. We appreciate your continued support and collaboration to reach as many people as possible because we all have mental health. Thank you. Please visit namivermont.org for more information or connect with us directly. And I have just 3 small pieces of paper for you. A quick brochure of the programs of what we actually do and how to get in touch with us. A save the date card for that fun walk. I know that Daisy will be there and we hope many of you join us for that day, a great day of human connection and relationship. And then I'll also just leave you my contact information, but I would again be happy to speak individually or collectively at any other time. Thank you for your time today and I'm happy to answer any questions.
Thank you. Go ahead, Copper.
Thanks for coming in first.
It's my pleasure. Thank you for the opportunity.
I have a question. Do
Certainly.
you know if UVM is involved in any research or any studies concerning mental health causes and things like that?
I can't speak directly to research. I can tell you that we partner with UVM on a number of fronts, ranging from helping to train their nursing students to working with their psychology department. We're currently working with Reba Porter, who also sits on our board of directors, who works at the hospital to bring the UVM connection to the hospital to actually have a support group in inpatient stay at UVM. That's in progress right now to get that group going. But in terms of the research, I honestly can't speak to that directly. I'd be happy to try to find out and get back to you. But
What my follow-up question was going to be, tell us a little bit about what you're doing with UVM. You just did that.
oh, great. Yeah, there's a number of ways. We go to many, I guest lecture outside of this. I guest lecture at 5 universities in Vermont, both on education and mental health. So those relationships now have helped to introduce NAMI, and we go to college campuses and do that Ending the Silence. We also do a very short presentation, not dissimilar to what you just had, with a little more zest, and a PowerPoint about NAMI, so they know like how to access our services. But we also do a program called In Our Own Voice, which allows someone who is deeply affected by mental health to tell their story in 3 parts on a college campus, which is what happened, what helps you, and what are you looking forward to? So it always ends on a note of hope and inspiration. It's someone who's already gone through their challenge and is really on the other side. I often partner and I teach about NAMI, and then my friend Jody, who's a part-time staff member at NAMI Vermont, who allows us to share her story openly. I'm not speaking out of turn. She's a published author. She writes about her experience, but she's also an incredible speaker. And she is someone who's affected by auditory hallucinations, meaning she hears voices all the time. But she's an author, a mom, or I should say, and she's an author, she's a mom, she's a friend, she's a colleague, and an incredible speaker and writer. She writes beautiful poetry. And when she tells her story, it immediately breaks down some myths. You know, people say things like, well, I can't tell from looking at you that you hear voices. Like there's a lot of assumptions or stereotypes that in a 20 to 30 minute talk, Jody breaks those down pretty quickly for people. And she also graciously allows them to ask her questions that might be tricky or might be uncomfortable or not typical. And she answers them all with grace and vulnerability. So we're really fortunate to have her as part of our staff. So there are those presentations. So when we go to college campuses like UVM, we often do Ending the Silence, In Our Own Voice, and About NAMI, sometimes all 3 on a regular basis. But we're happy to go anywhere. We just went to the Lions Club recently, like in services for teachers. We're really happy to go anywhere where there's an interest in having a safe conversation that's facilitated for people to learn about resources.
Thank you.
Thank you.
Good work.
Thank you.
Question, you said you were an educator in schools.
I am.
What,
Was.
I don't know how to present this question, but what would you like to see more in the mental health capacities for elementary and, or what are we missing in those schools?
That is like my dream question. And how much time do you have? So as a principal of 28 years, I would love it to just be part of the curriculum. Starting very young, right? And so we're not going to go into elementary schools and talk about suicide prevention, but we absolutely should be teaching part of health, not just nutrition and what you eat. We should be teaching brain health from day one. We should be teaching self-regulation skills. And it should be part of the curriculum because these are the life skills people need to solve problems, right? And so it's applicable across the board. It's not just one content. It applies to every relationship you have from here forward. So I definitely think it should be available for everyone in a consistent, scaffolded, planned way with intention and purpose. And I also think sometimes best of intentions don't always land. Outcome and impact sometimes don't match, right? So we say like we have a high school guidance counselor. That is phenomenal. That's great. But you know what? In order to go see that high school guidance counselor, you have to miss a class, make up the work. It's not like you're asking the student to make further accommodation to be brave enough to ask for a service that they need at a time that doesn't necessarily work for them. It's based on the adult schedule. Like there's got to be better ways that they're not being penalized. We have to make it easier to access those services and more universal.
Can I follow up question?
Please.
When you say part of the curriculum, what intent do you mean that?
I mean, we have PE class where you work your body.
Yep.
We have health class where you learn how to eat your vegetables. We need to incorporate into that health class. How do you take care of your brain? How do you self-regulate? What do you do? We need to teach from day one that mental health is on a continuum. And there are hard days and sunshine days, but like you're not stuck there. You have the ability to self-regulate and what helps. So even with young children, when we just call them really big emotions. I taught first grade for 8 of my years, right? I've had conversations with kids every day about, they're throwing themselves on the floor. And my question is, wow, you seem really upset. Did I get that right? Or I say, hey, you seem really sad. Did I get that right? And they say, no, I'm not sad. I'm mad. Well, that's good for me to know because I'm going to react different. My response is going to be different for sad or mad. So I think we have to teach educators how to ask the questions, but we also have to provide space and time and opportunity for kids to have direct instructions in things like self-regulation. We figure out on our own as adults and maybe through our teens, things that help us. If I asked right now, if you had a crap day, let's just pretend, not today clearly, but put some day. When you went home, what would you do to help yourself feel better? Seriously, let's just take 10 seconds. What would you do?
Text a
Meditate.
friend.
Meditate, text a friend,
Yoga.
pet your dog, listen to music, go for a walk, drink some water.
Water.
I said water. Yeah.
Thank you.
Time and place. So I'm saying we have those skills. But what if we asked 5-year-olds that same question? When you have a big feeling, what do you want to do with that? And then we record their answers and then we leave it hanging in the classroom. And when someone's on the floor, we say to them, you and your friends came up with this great list. I want you to go pick 2 and try it and come back to me in a minute. You have to create time and space for those learning opportunities as they present themselves. You can't just teach it in a textbook and hope they put it in somewhere, like they apply it somewhere. With little people, they have to feel it, see it, touch it, do it. There has to be time for that. And the schedule for any public educator today will tell you it is crammed with stuff. And so mental health to me has got to be more of a priority and given time and resource in schools because it's going to affect every relationship there forward.
Appreciate it.
Thank you.
Please.
I'm gonna have to invite you in if we take off this bill H 817, if we take it off the wall. It's introduced today, but it's all about mental health literacy in schools and
Amen.
that and everything that you just spoke to. So
I would love to learn more about that
yeah,
or to have an opportunity to support that.
about it. And also just thank you for everything that you do in your leadership at NAMI and for being here today.
I appreciate the opportunity.
Also, I want to be sure to recognize my chair because she's the one that actually invited in all of our
Oh,
people and
thank you.
advocates. And I don't think another chair has really carved out as much time as this one has. So
I appreciate
very lucky
that.
to have her.
I think those lived experiences and to bring a lot of power to the power and information, right? You need data to make informed decisions. And so I just look at this as an opportunity to give you some more data to ponder and to reflect on and to ask your own questions about, what's working well, where are the gaps, how can we help? And then it's really difficult to prioritize and they have a tough job ahead of you, but I'm happy to assist any way I can. And I appreciate the opportunity to share.
Brian has a question, but just speaking of gaps here real quick. Center for Health and Learning
Yes.
recently
Closed.
closed.
Mhm.
Um,
In transparency, I served as their executive director for a period of time prior.
and, you know, they were the nonprofit that sort of served suicide prevention.
Yes.
And as a suicide loss survivor myself,
Thank you for sharing and being vulnerable.
I'm wondering if NAMI has sort of taken on any of the things that we had kind of tasked
Mhm.
Center for Health and Learning with,
Mhm.
to hopefully close some of the gaps.
Yes. So again, I want to stay in my lane. Lori Emerson is our executive director. She will be with us through June. She is leaving in June. She's retiring after 14 years of leadership. Those will be big shoes to fill. And in doing so, in conjunction with that, we are creating a strategic plan right now and just beginning those conversations. The Vermont Suicide Prevention was obviously part of CHL and a big chunk of my area of expertise and work. And so I would very much like to see NAMI expand their work. I think it's going to be, I know it will be a huge loss to not have CHL, and there are a lot of relationships in place that should continue. To that end, VAMHAR was able to rehouse the You Matter curriculum, and they have that trademark. And I have met twice with VAMHAR in the last week to have conversations about how are they updating that curriculum and how can I help to make sure that that curriculum continues, because it's very strong. And I've trained it many times in many places, and I'd like to see it continue. So, and I told them I would be happy to do that as a NAMI affiliate or as just a human being who has interest in continuing to see that go. So whether it's with a NAMI hat on or a suicide prevention hat on, I think we have to be really intentional about that. And so some of that curriculum will land at VAMHAR. I absolutely think there is a gap in need, and that NAMI, with some preparation, could staff up, given grant opportunities. Again, small nonprofit, it has to be funded. So I would love nothing more than to see an opportunity for suicide prevention to be rehomed or housed and allowed to expand across the state. It's an absolute, it's a need. It's life-changing and life-saving. Yeah. So I hope that that's the case. It is in discussion. We are definitely talking with VAMHAR. And then just from my lived experience, I know how critical it is. And while we can have individual conversations on many places, it's really important to do that in an organized process way. And so I hope there is an opportunity for NAMI and other small nonprofits to do that work in coordination with our designated agencies. I do want to give credit to the designated agencies who are doing really creative things like urgent cares that you can walk into for mental health, right? In addition to the ER. The ER does everything they can, but I'm going to tell you, as a consumer of service and someone who sits with people in the ER, it's not a therapeutic setting, right? If you are already under anxiety, that's not a great setting, and yet it saves lives. It's what we have. So this idea of community-based walk-in mental health, the one that Howard's doing, I know there's one in Middlebury with CSAC, I think is critical, and I'd like to see those expand as a way of access. So yeah, I think we have a lot of work to do, and absolutely CHL and VTSP will leave a gap, and we need to be intentional about how are we going to fund and who's going to do that work, but there's an absolute need.
Sorry to interrupt you, Brian, because Brian has a question, but
Certainly.
you said gaps and I immediately.
Well, that is a gap.
Yeah.
You were talking about making time and space in education system.
Yes.
To teach humans as they develop emotional regulation skills. However, many humans miss that opportunity, and now they work in places that are not good for their mental health. And so I'm curious, like,
Amen.
if you have ideas about how we might better improve the working conditions for people to improve the mental health of our population and quality of life.
Excellent question. And yes, I would agree with everything you just said. And I think there's an absolute place for workplace wellness, right? We have to start where we are. So it's great if we can be preventative and help the youth do it another way now that we know, but we also have to start where we are. So I think that goes to NAMI partnering with businesses and other places to do in-services and facilitations. And, when Jody comes in and talks about her mental health, even when I say sometimes to a group of people, there's not many people places you go where you say, hi, I'm Kathleen and I'm a suicide loss survivor. Like, that is not your lead. Do you know what I mean? So we have to create safe spaces for those conversations. And I think that has to be at the top of businesses to create retreats, in-services, staff meetings, and make it a priority to use the free resources that are available so that people can access help. I mean, when I go and talk in larger groups, I often ask, raise your hand if you know what 988 is. 988 has been around a long time, and we're getting less than half of the hands go up. We have work to do. Like, Schools are a little better, schools are a little higher, but when I go in the business world and say, what is 988? And that's on us. If half the people don't know, that's not just on the people, that's on the human service field to continue to put it out, to market it, to make it accessible, to explain it, to take off the stigma, to, we have work to do for sure. So workplace wellness, I think that should be in the strategic plan. 110%. And we really have a lot of work to do around stigma, right? Just really quickly, last quick story. When I present, I often help frame for people how big that stigma is. Let's pretend you were taking down your holiday lights, you fell off the ladder and you broke your arm. You would go to the, where? ER.
Urgent care.
And what would they do? You go to urgent care or the ER. And what would they do? They I hope not. My goodness, let's not jump to conclusions. They would x-ray it, they would assess it, and they would see that it's broken. We're gonna pretend your arm is broken. And after assessing it and seeing that it's broken, they would put a cast on, which would support it temporarily while it healed. When you went to work on Monday, you would say, oh, you won't believe what happened. I fell off the ladder, I was taking down the lights, blah, 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 I broke my arm. And because people can see that you're in a time of temporary need with that cast, they would say to you, can I carry your coffee? Can I open that door? How can I help you? Because they can see it. Let's tell that same story again. I'm going to change just one factor. Instead of breaking your arm this past weekend, you had a really difficult weekend emotionally. You lost someone you loved. You're under a lot of financial stress. You're not sure if your job's going to lay you off. You had a really dark day and you went to the ER for some mental health support or maybe even a suicide screener. How many of you are going to go into work and say, hey, on Monday, hey, I went to work and this weekend I went to the ER for a suicide screen. Are you going to share that? Honestly?
If you try to talk about it, they're gonna be like, move on.
Well, listen, and why not?
Yeah.
Why not? Why won't you share that at work? Stigma,
You get judged.
fear, judgment, seen as not competence. You're afraid it'll change your work performance,
People will treat you differently in the future.
future. So here's our job collectively. We have to make it as safe to talk about that cast and physical break on our arm, our physical health, as it is our mental health. That is the work ahead of us. Because really, it's quite similar. That same person who has having a difficult, dark weekend needs support. It needs an assessment, it needs support, and it's a temporary time of healing. They're not going to be in that place forever. It ebbs and flows. But we have to be able to have places that people can ask for what they need without that stigma and judgment. So that's our work at NAMI, and that's what we need your help with.
Thank you so much and thank you for your work.
Thank you. My pleasure.
Really
To speak with you. I'd love to just
sharing.
pass around those quick, if you don't mind, just take one and pass it around. And I'll leave you my card. Happy to speak with any of you. And if you'd like us to come to your your Lions Club, your Circle of Faith, we have a project called Faith Work. FaithNet. We'll speak at churches. We'll speak anywhere anyone willing to listen.
I have a daughter that's in the elementary setting, 20-something years.
Well, thank you for her
She
service.
talks about this all the time.
Thank you,
but
Kathleen.
Thank you.
We have.
we just don't address it. Thank you.
Thank you.
Actually, did you get the message?
Yeah, I had an email.
You got with it? All right. All right.
Sasha, I'm sorry, do you hold for yourself? If our next guest is here, is it Phoenix? Okay. I guess we're moving on. Alexander, hi.
I did get an email from someone saying they couldn't have access, but I connected them with Tasha, so I'm assuming that.
Any other extras coming around the table, brochures or cards that I can take back?
No,
They got
They stopped when they did stop. Sorry. I held them up.
I just,
Got lots. I'm sorry, would you mind giving us one brief moment?
Sure.
Who did you? Are they coming?
From someone.
I think they're
that
stuck.
Wants to talk someone with lived experience, so we'll take after this hour.
Yeah,
Let's send those around.
Can you send that to me, please?
Yeah.
Before, yes. Okay, we're pivoting. You've got our full attention.
Thank you. Thank you, Madam Chair and committee members. And thank you for your presentation and for all the work that NAMI does. It's such an important part of advocacy and support of families and stigma busting in the communities. Great to be hearing more about what's happening. I'm Alexander Smith, Director of Adult Mental Health Services at the Counseling Service of Addison County, and people often refer to me as Sandy. I go by he, him pronouns. And I'm here to speak about the impact of the mental health urgent care initiatives, in particular our program in Addison County called Interlude. And part of the timing of this right now is that Interlude's funding is uncertain after the end of the grant at the end of June. So we're here to in part advocate for that, and also I think also just speak to what's happening in the urgent care programs, and I think a really important aspect of these programs that they're just very low barrier. And I think Interlude, some of the ways that we put this program together really exemplify that. In this next stretch through the legislative session, and while we're here today, I think there's three main themes that we're going to be advocating for. One is continued funding of Interlude beyond the end of the grant period. Two, that we do what we can to support a firehouse model of funding for these programs that we think is critical to their success, so that as other crisis systems, you're paying for the capacity for people to be available, and then you're less reliant on billing and other procedures to bring in the revenue. And then three, for the Interlude project, it's almost entirely staffed by peer staff. All of the other urgent care programs work from, have peer staffing as part of it. And we really have to keep thinking about how those roles can be fully supported and sustainable, given what we're asking people to do in this work and how much they put of themselves into it. To give a little background, Interlude came out of a work group over a period of 2 years of family members, clients, and staff. And we were really just trying to figure out, what can we do to impact the amount of involuntary hospitalizations happening, impact the experiences that were happening in emergency departments where it would be crowded and stressful and people could end up spending a fair amount of time waiting for a hospitalization. And we heard of funding opportunities eventually that came forward first from a federal earmark supported by the Sanders administration. And we were one of the groups that got started with that earmark. And then the legislature supported a grant process that's facilitated by the Department of Mental Health that was our continued source of funding. The model that our work group came up with was to offer alternative crisis support on weekdays, offering a welcoming and comfortable space based on the concept of this model called the living room model. The staff would work from this approach called intentional peer support, which is kind of a core practice in the Vermont system of care. And we also brought in the influences of another practice we've been working with at CSAC for the last 14 years or so called Open Dialogue, which is more of a clinically developed practice, but very similar to intentional peer support. And what's really important about this is instead of greeting people with a lot of forms and pre-populated assessment questions, our staff would just prioritize meeting people, welcoming them into the space, taking time to hear what's going on, what brings you in, and really, sorting out with them, what's going to be supportive to you right now. And while all of the urgent care programs in Vermont include peer support, Interlude is unique in that it's the only program that doesn't co-locate clinical services in the actual space, but we quickly refer to people to other more traditionally organized services if that's what they're feeling they need. And the staff focus on listening intently, offering mutuality, letting people define what they need, and giving things some time, which almost always allows, whatever distress just to ease enough for things to seem more manageable. In terms of results, I have to say, I've been working in the Vermont system of care for over 40 years, and what we're seeing with the kind of engagement and connection that's happening so readily, so easily in Interlude is something that just really stands out to me. Through the calendar years of 2024 and 2025, Interlude has met with 143 people with mental health crises through about 1,200 encounters. Not included in these is another 15 to 20 open dialogue network processes that Interlude staff have assisted with offsite. And these numbers are smaller than other urgent care programs. But when you kind of calibrate that to the population region we're serving, they compare pretty well. And for Addison County, we think this is a very significant impact. People have come in coping with mental health crises of all types and levels of acuity. Interlude has had notable efficacy with people who really have some wariness, distrust of mental health services. We're really seeing a very different dynamic with a sense of approachability for folks who otherwise aren't finding their way into care. Since the start of the program in 2023, only one guest has gone over to the emergency department, and that was something they had just decided they needed to do. There have been some situations where Interlude staff have assisted people coming out of the emergency department in averting a hospitalization altogether. Guests have shared that Interlude literally has saved their lives. Some have commented on the sense of safety and trust they quickly experience after they walk in the door, and how different this feels from when they have tried to seek mental health support in the past. Some have expressed that they feel they can speak to things that otherwise they fear would get them locked up. Others have commented on the experience of talking to people who get it, who have been through similar challenges with mental health conditions, as well as adverse experiences in some service systems. One person who had come while in crisis and also coping with the extreme life stressors of being unhoused and without work, came back after many months of no contact, saying they're now housed, employed, feeling good about life, and they just wanted to thank the staff and see where this path had all started. For some people, this has been their first point of engagement in services. There are others who have a broader range of mental health involvement who have added Interlude into their range of options for how to get support when times get hard. The staff sometimes go offsite to offer support in other settings, including the emergency department. And when circumstances allow, they also participate in open dialogue network meetings with guests in their personal networks in an effort to collaboratively understand and plan for how to get through the crisis at hand. And this way of meeting in times of mental health crisis is also an area that we've just seen really remarkable results. So another data point that I want to note is that CSAC has been running at a population adjusted rate of involuntary admission that runs well below the state average, and like a half to a third. And we think that Interlude's played an important role in these results. And we're also experiencing something that we've heard from other peer-led crisis supports, which is we haven't seen aggressive reactions in this environment. And we hear this from other peer-run centers. And we think it's the difference in relational dynamics that people are being met on a eye-to-eye level dynamic, and also the lack of institutional cues in the environment. So
Can I ask a clarifying question?
Sure.
I'm intrigued by something you just, and I want to make sure I'm understanding.
Sure.
CSAC has a lower service population than, say, other designated agencies in relation to the population of Addison County. Is that, and is there a correlation between Interlude and this? I mean, have you noticed?
The lower admission, are you asking about the involuntary admission rates?
Okay, I wanted to,
Yeah,
I wasn't clear that, so we're talking about involuntary admissions.
yeah.
Okay.
But we're also a smaller agency in a smaller county, and I think the numbers has been one of the issues around kind of longer term funding for Interlude. So, for our population base, we think we're doing pretty well, but
And has that number been going down since, how long has Interlude been there now?
It's been running, we had a soft start in the summer of 2023, but it's been running full tilt for the last 2 years. I'd say we've diverted some admissions in some involuntary situations for sure. And, I don't know that it's a direct kind of linear, because our numbers were already low from things we've been working on, but it's definitely helped kind of sustain a dynamic of finding other ways to engage with people and head off something that, has more impact.
Thank you. I didn't mean to interrupt, but
That's
that was,
important.
I wanted to clarify that because that's really important.
Yeah, no, thank you. How are we for time?
Oh, I think we're good.
Okay.
Oh, they are. Okay, so another couple minutes.
Okay. So, I guess just to emphasize the role of peer support is a key part of this. The atmospherics of a space that is decidedly like the opposite of the experience of being in a stressful, busy emergency room, that this is a comfortable, welcoming space that people would want to go towards in the time of distress, rather than if you think about what an ED is like, that's a hard space to be in if you're struggling with other things internally. And then the very low barrier availability, which I think is really critical for the funding models for the urgent care programs, that we just make it as easy and approachable as possible. And for Interlude, we have a number of people who have participated anonymously. And that to me tells me that these are people who wouldn't be getting in somewhere else, or they wouldn't, if we hit them with some billing forms and intake forms, I don't think that would have gone very far. And so I think this is one of the most important points about if we can find ways to support these programs going forward, to really try to fund it in that way. I think those are the main points. I think, in terms of impact, one of the toughest issues in our system of care is when people really seem to need treatment and yet aren't finding their way to choose treatment. And that can be really impactful on families. It's a big stressor and worry for our treatment teams and crisis responders. It can be impactful in communities. So anything we can do to make these programs as approachable, to make services help as approachable and, feel safe and comfortable for people to approach. I think it's really important that we keep developing that edge in our system of care. I'll stop there and see if there are any comments or questions.
Leslie?
My only question or request, could you share your testimony so that we could review it and?
I did submit a written.
Oh, yours
version
are
of that.
I'm
Yeah,
happy to submit,
Thank
and some of it is off script, so yes,
Yeah,
the first part is
so
all written and the
whatever-
rest was
Whatever you have.
in the moment.
Yeah, thank you. And we know how vital this resource is, because we know that our Agency of Human Services is looking to expand with the rural health transformation, ensuring that all communities have, mental health urgent care.
it could also help us bridge
It could
another year of
help-
funding. That would be fabulous.
I was going to ask you if you would be able to expand your hours if you had increased.
We would love to. Our first worry right now is continuing beyond June, but if
Okay.
there was more to build on, we started experimenting with Saturday hours and shifting back our weekdays, and we were getting some good responses on Saturdays. So, there's much more we could do if we had the means to do it.
Thank you. Thank you very much.
As an consumer, I just want to
It's a
say,
pleasure. Thank
Interlude and our both experiences highly valuable as someone who sits with someone who's in crisis in the moment. It makes such a difference. So I just want to back up everything. I didn't know that's who was speaking after me when I spoke previously, but 110% needed and the way to go. My success.
Thank you.
Yeah.
We have somebody else joining us on Zoom. Tyler?
Hi, how you doing?
Hi, Tyler. How are you?
I'm good.
Can you just introduce yourself? Introduce yourself to
Yeah, I'm
us.
Tyler Sears. Tyler Sears. I got a history of substance abuse. I'm currently at the Virgins location of Valley Vista. I wrote something I'll read to you guys. My name is Tyler Sears. I'm 35 years old from Burlington, Vermont. A recovering addict with over 90 days clean now. I've spent over half my life in jails, rehabs, and institutions, and no longer am addicted to substances. I've managed sobriety a couple times in my life, but nothing like this most recent time with it. I was locked up in October for a series of misdemeanors stemming from substance abuse, unlawful trespassing in City Hall Park, and retail theft. When I was locked up, I had a prior authorized prescription for Suboxone, but didn't see my medication for 11 days. And even then, it was only gradually increased from 2 milligrams, not the 24 hours prescribed. When I was inside the jail, the officers responded to self-harm incidents, managing psychosis, and trying to de-escalate crisis despite not being mental health clinicians. Inmates with serious mental health problems are being managed, not treated in Vermont prisons. Prisons are being asked to solve problems they were never designed for, and then blaming the very people we're supposed to be trying to rehabilitate by saying they don't try enough or their behavioral problems are too much. People like me are told that this is an excuse, not that it's because we have a chronic relapsing condition that involves the compulsion to use and a lifetime of mental health challenges. You're taking very highly traumatized people, putting them in a further traumatic environment, and asking them to behave perfectly, and most are nonviolent, non-listed offenders. I've talked to many people high on the totem pole of rehabilitation. We all share the same thoughts with DOC, saying that they're going to start offering substance abuse treatment. Their idea of this has been on an app or a tablet, not something taught in a classroom by an actual clinician. If the clinician was to be brought in there, the only way it would work is to have these inmates housed in a specific unit away from general population. Misery loves company, and the inmates there are not focused on their recovery would do anything possible to throw the other inmates off. I was there. I know how it works. I know it doesn't. If money's spent anywhere, it should be in reintegration back into the community, transportation, and getting people set up with treatment and community resources. I was blessed to have left jail and went to Bradford's Valley Vista for 30-ish days before coming here to Virgins. Bradford was a great residential treatment where I got the necessary 30 days that it takes for the brain to stop thinking that it needs the drug and to learn new coping strategies. It was through Valley Vista that I met Kevin Hamill, Vice President of Clinical and Medical. The opposite of addiction is connection. Jess Kirby, my substance abuse counselor, not only drove me to Valley Vista, but connected with me the whole time I was locked up. And Vermonters for Criminal Justice Reform, where she works, has been there with me throughout the worst days of me getting high, and a big part of my recovery as well. Having someone there for me when I was released made all the difference, and just alleviated the stress of court and getting sentenced. I believe, along with many others, that the answer lies in the data of the 3.1 program of Virgins. Treatment and evidence-based at that, while finding the Valley Vista would open 3.1 beds and even allow residents in Bradford up to 90 days instead of 20. It takes longer than 20 days to fully stop wanting the drugs as a way to comfort and relieve stress. It's also known to take the brain 90 days to a year to begin rewiring its reward system through extensive treatment. I know this from personal experience that addiction is a trauma response and a way of coping with underlying issues, the only way that we're taught to work. So that obviously means that if an addict is taught better ways of coping that relieves stress and reduce cravings on top of being connected with a support system to benefit their specific treatment and therapy geared towards the underlying issues they were using to self-medicate to begin with, that means they have more of a likelihood of remaining sober than incarceration. Recovery requires hope, continuity, and agency, and jail takes away all three. I took the time to this 3.1 to write a book called But I Stayed, outlining all of this and giving myself purpose, another staple in finding recovery. Vermont needs the money invested into 3.1 residential treatment programs, not jail, with a lack of coordinated entry, where people are having their tolerances to substance lowered and then thrown back into the street, no aftercare plan, and with drugs that are strong enough to kill people now. The first 2 weeks after release is the highest risk for this to happen. If lowering the addiction rate is the goal, it starts with stabilizing people, not just long enough to release them from jail into the same drug-infested environment they've come from without any counseling under their belt or trauma-based therapy. Instead, they leave jail without release planning, inadequate dosing, or forced changes in medication. On top of that, incarceration also worsens trauma and anxiety, and especially for the ones that are already unstable. Cycling through jail disrupts housing, employment, family reunification, continuity of care, and they are released in the worst positions than when they arrive. It's not lowering the chance of relapse or giving the necessary treatment to stay from situations that end in substance abuse. The change can start here with you expanding treatment, not incarceration, putting a cap on the amount of people or amount of time someone spends in jail before being admitted to treatment. And in that time, having them screened while they're drying out in jail and then admitted. And by guaranteeing uninterrupted in jail while substance abuse treatment is being set up with a strong aftercare plan in place and being inducted into being induced within the 24 to 48 window, but that hasn't been taking place. We don't have taken into account how easily people are incarcerated and it affects on their mental health, self-esteem, and substance abuse. That's a very big step back that typically takes place after a minor infraction. It's a big reason some people struggle with substances so badly. I hope that we can move away from incarceration for people with substance abuse and instead invest in programs like Valley Vista and VCJR who are supportive every step of the way, from overdose to jail to long-term recovery and everything in between. Thank you.
Thank you so much, Tyler. And I'm
I appreciate the
so
opportunity.
grateful that you're finding the supports that you've been seeking.
Appreciate
Do you have
it.
a question?
Can we ask you
Brian?
some questions?
Yeah, no
Yes.
problem.
Okay, so I'm Brian from Burlington and I'm wondering if you could say a little more. You said VCJR. I know what that is. I don't know if everyone here does. Could you say more about what that acronym means and what is some of the specific things that are working well for you right now through that program?
So VCJR is Vermonters for Criminal Justice Reform. It's in the downtown area of Burlington on Bank Street. They do substance abuse counseling. They set up all your meetings, get you like reintegrated back into the community. One-on-one counseling. They do UAs. They report back to the court or whatever, like probation, whatever you're in. If you're in jail, they'll take phone calls from you. They'll set up your treatment from there. They'll get you to rehab. They set up rides. They really do like basically everything.
Are you doing are they doing contingency management with you at all? Or
Yeah.
Can you explain to the committee what that is?
I right now I'm in Valley Vista, so I'm like the only thing I get from there right now is counseling and like
Okay.
over the phone, like Zoom or telephone calls.
Okay, so it's counseling you're getting then. Okay.
Yeah.
Um,
Substance abuse counseling.
Yeah, the other question I had was, you were talking a lot about how when people are incarcerated, it makes things worse, not better. And can you say more about the harm that occurs to a person when they're put into incarceration?
Well, in my case, it helped me for a second. Like I don't believe that like long-term jail is like the answer for substance abuse. A minute away from the drugs is the only thing that benefits. But so if that minute is taken in getting people treatment and you know what I mean, yeah, it's great. But if you're ripping people away from families for a sensitive period of time, like that first week and a half you're in jail, you don't even really get a phone call. Like you don't get to touch base with your family. It takes like a week and a half for you to get a pin sheet in where you're allowed to like have allowed people on a list to call. And that does something to somebody's mental health. Like I don't know, it just breaks you from society. Like we're trying to teach people to reintegrate and like be able to be out there in the community, and putting them in a hole or putting them in jail, it's like the exact opposite.
So it sounds like what you're saying is it's
you get around
helpful.
people that have.
Right.
Go ahead.
Yeah, there was a glitch and I thought you were done and I didn't mean to interrupt you. It sounded
You're
like
good. Go ahead. Go ahead. Ask what you're asking. Go ahead.
It sounded like what you're saying is it's helpful to have people step in and interrupt the cycle of addiction, but it's not helpful to then isolate people.
Sometimes it's necessary.
Mhm.
Right. You know, it's not helpful to isolate, but like people in like my sense, the only way that I was going to stop was to be ripped away from the drugs. So whether that looked like treatment or jail. Do I think that months in jail is the answer? No, but maybe a 2-week period where like people can get to work on treatment and like the aftercare plan, because that like really that's the definitive thing. Like, you could take somebody away from drugs, but drugs are always going to be a part of the world. It's the aftercare plan. It's the process of, all right, what are you going to do after you stop doing drugs? That's like the biggest part. Like you need like a step-by-step thing to follow. Like, oh, if somebody comes up to me with drugs or asks me if I'm going to use, this is what I'm going to do. Or if I find myself in a situation where there's drugs around or people who think like that, this is what I'm going to do. This is who I'm going to connect with when I have cravings. This is who I'm going to connect with to get my probation, and this is not in hand. You know, like it's the planning that's really the biggest part.
Thank you. Thank you for joining us today. Really
I appreciate
appreciate
it,
it, sharing your experience. We're gonna take about a 2-minute break just to change the room over. And
You guys.
we'll be back. Thank you so much. And thank you to everyone who joined us today. We really appreciate it. And we're gonna actually continue this later this afternoon. Okay, thank you.